Okay, I think we're ready to resume. And the next item is item 8, which is the Integrated Performance and Quality Report. And I'm going to hand over the baton to Maestro David Park.
Thank you, Boyd, and thanks for the introduction. Colleagues, I'll have a copy of the September update for our IPQR in the board papers, as well as the covering SBAR, which tries to summarise our overall position, as well as pick out some key highlights from the report, and share some of the national benchmarking associated with them. Not all national benchmarking data is available across all of our metrics, but we've been able to put some in there which shows our performance not only in absolute terms against target, but against the national averages, some of which show favourable and some less so, and that obviously is a focus for us. I think the system pressures that we referred to earlier are very much an overriding factor in our ability to meet our initial remobilisation plan. I think as the remobilisation plans were set and submitted to government previously as our MP3, we, I think, all assumed that we would be further on in our recovery against COVID, and the pandemic impact would not be to the same extent. But I think both locally and within the board, as well as nationally, we're seeing that not to be the case, and that we are constantly having to adapt our plans and our services based on the most critical care needs. I think that the other thing, just in terms of introduction, and I'm going to we'll go around the various sections to mention, cancer has been mentioned a couple of times this morning, both in terms of the action log as well as in the commentary. There is some detailed information within the pack with regard to both our 31 and 62-day cancer performance, and you'll see that the impact that Catherine was describing, a positive impact that we're having in those metrics, is showing, and that's encouraging indeed. So without further ado, what I'm going to do is sections 152 through to 165, or pages 152 to 165 rather, in the report covers primarily our scheduled care as well as our emergency care. I'll maybe ask Catherine to add some further commentary to that, and then maybe invite Alex if he wants to add any comment from a governance point of view.
Thanks, David. So you can see from the information that you've got in front of you in terms of the emergency department response, we are struggling to deliver the normal standard of 95%, mainly because of the new flows that have had to be put in place to manage COVID. So all people attending emergency departments do need to be considered as to whether or not they're COVID positive, and that has put in some significant challenges into the reasonably small footprint areas that we have to flow through the emergency department. Other challenges in those areas for us obviously are flow into the hospital, and again, because of our COVID pathways and because of some of the pressures in the system that we've covered earlier today, we are continuing to see emergency department performance that is less than the 95% standard. Work and mitigations that are going on in this area are a number of both rapid response and slightly longer term strategic changes that we plan to bring forward, working very closely between myself and Louise. Some of that relates to us increasing some available bed capacity, particularly within the medical division at Raigmore, and also working with Louise and the community teams to increase capacity to support discharge to assess currently. So happy to take any questions on that at the end. I'll just move on to the next item, which is the new outpatient. So you can see that we are delivering reasonably well across the new outpatient plan that we had agreed with Scottish Government. And the main challenge to us delivering in that area is within Argyll and Bute. Within Argyll and Bute, obviously we are reliant on availability of services to deliver from the Greater Glasgow and Clyde area. And Fiona may want to come in relation to some of that at the end, but we have been in conversation with Scottish Government over that. We are working very closely with the teams in Argyll and Bute and indeed with Greater Glasgow and Clyde to look at every opportunity to increase capacity being provided in that area. If I could move on to the treatment time guarantee, we have been continuing to work in this area. The main challenges in this area are again around the capacity to deliver in the Lawn and Isles area, and that relates to some Greater Glasgow and Clyde capacity and some surgical capacity within that hospital. And we're looking at mitigations, working closely with Fiona and the team in Argyll and Bute to manage that. We have remobilised our orthopaedic services, and they have been stood up and have had to have a period of pause, as you'll be aware, through the period of August. But again, those orthopaedic services are up and running and have been running through challenging times. We're delivering a pretty good performance in terms of the volume of operations through that period. And I think the timescales for this report go towards when we started to see the most recent surgence of COVID. So performance in relation to that will come in a subsequent performance report. Looking at our 31-day standard, we always deliver a pretty consistent response in terms of this, and that has continued. We have opened our Highland Urology Centre that is giving increased capacity and one-stop attendance for patients coming in for urology cancer diagnosis and treatment. And looking to the 62-day cancer waiting time performance, where we have been most significantly challenged, we have, as you are aware, put in significant effort and concerted effort led by our Cancer Services Manager and Cancer Clinical Lead, Nick Abbott. And we are seeing a significant improvement in terms of our compliance rate with that standard. Currently, we are delivering the standard, although that isn't actually reflected in this report. And finally, scopes and diagnostics, we continue to deliver activity levels as expected, and we monitor those deliveries weekly to ensure that we are on track with that and managing the challenges that COVID has put in, again, to delivering those pathways. In terms of our emergency admissions, we had an expectation that the number of emergency admissions would have been at a level, as you can see there on the report in front of you, that we had an increased number of emergency admissions through the period of May going into June, and that did put some challenge into the system, particularly in relation to flow into our pressured bed capacity that we have alluded to and discussed through this meeting. So I'm happy to take any questions at all on that, David. I'm probably best just to pause there at that point. Thank you.
Thanks, Catherine. That's helpful. We'll maybe keep the questions, if we can, to the end after we've done the updates, and that allows colleagues to look across the various sections, if that's okay. Alex, did you want to add anything from a performance point of view?
Just to reiterate the good work that Catherine and Louise and the team are doing. I mean, clearly there are still issues in terms of the numbers that we have, particularly in the A&E admissions. But we were really pleased with the cancer, and not just the numbers, it's the process that is now being undertaken. and we will benefit from that in the fullness of time. Thanks.
Thanks, Alec. And I think just to highlight, I should have done earlier, that some of the traditional metrics that we have around this, that you would see in the SBAR, for example, around adherence to 12-week targets for outpatients. Given the situation as we come out of a pandemic phase, then clearly our waiting lists are longer than what we would, and we're going to be seeing patients that are either triaged, particularly at a TTG level, that have been assessed, but certainly we're going to be looking at your longest waits. So as activity steps up, this number is not going to move positively for some considerable time. So we will need to look at the metrics that we use so that we can actually look both subjectively when we compare ourselves against our plan, but also objectively in terms of where we are against the whole. So because that ultimately is our patient experience. But there are some metrics that we will need to look at from slightly different angles so that we give a truly reflective picture. Thanks. So if we can move to the clinical governance section, which are pages 166 through to 181, and I'll invite Boyd first of all to add some comments, then Heidi, and then Gaynor as Chair of Clinical Governance.
Thanks, David. Boyd Peters, Medical Director, and the IPQR is used in clinical governance meeting as an active part of the agenda, and with reviews at each meeting, usually concentrating on key elements in the report and looking to shape the report further and to perhaps put in other metrics in the course of time. In the version that is in the board papers, I would highlight, first of all, in adverse events, some work is ongoing to understand what is within the underneath the sort of headline figures, and at the same time there has been an internal audit which has been conducted, and we're awaiting the formal report with an action plan linked to that. And so that will be some work which will commence for us shortly on adverse events, looking at the systems and the overall of it. There has been some, for instance, very well received training, some parts of the organisation, including mental health service, and we expect that we will see some differences in our numbers as a result of that. On complaints, against the 20 working day standard, performance is still nowhere near where I would like it to be, and this is multifactorial and has been impacted by COVID, and we will need to do some more work and trying to get the response times reduced. Some of the complexity issues have been a factor in why that's been harder to achieve, and also because within operational units there are challenges in terms of the overall busyness of services that has affected, and it is a pattern that's being seen throughout the rest of Scotland as well. So those are my main highlights in it. The positives are in the continuing development of the report, and I would expect to see the version presented to change over the next several months now. And with that, I'll maybe hand over to Heidi.
Thank you, Boyd. I just wanted to really, I think, to talk about infection control, if that's okay. In relation to Staph aureus bacteremia, we remain on track to meet the national target, but with Clostridium difficile, we are struggling to achieve the national target, and I think there is a likelihood now that we will not meet the Clostridium difficile target by March 22. This is not the first time I've said this here, but the position has improved a bit, and that's excellent news. But I think it's going to be enormously challenging for us to meet that target. One of the other things that is newly occurring at the moment is that in terms of how we calculate our Staph aureus bacteremia and Clostridium difficile figures, we use acute occupied bed days as the denominator. And of course, during COVID, our acute occupied bed days reduced because we reduced the numbers of beds in the system because of social distancing and spacing, etc. So we are just in discussions along with all boards with the government at the moment, because all of us are going to see a slight increase in our rates as a result of that reduced bed number digit. I don't think it will affect us hugely. I think we will see a couple of percentage rise in our figures, but we need to do the calculations properly. And as I say, we're in discussion with the government, just so that you're aware. I'm happy to leave it at that and take any questions. Thank you.
Thanks, Heidi. And Gaynor, can I come to you? Is there anything you'd like to add as Chair of Clinical Governance?
Thank you, David. Not a huge amount to add. Really just to note that committee is in discussion about what measures need to be on the IPQR, and that will change, as Boyce said, over the next few months, so that committee are looking at a range of measures both within committee and ones that we've then nominated to be on the IPQR for board to see. So thank you, that's all from me.
Thanks, Gaynor. And you know, we're going to come to staff governance in a moment, but I think it's just worth mentioning at this point the discussion that we've had in developing the IPQR, and it is a moving document, and it's important that it stays relevant for the subcommittees of the board to reflect the review that they're having, and that's where the principal review and governance comes from. And then this within the board situation is very much a summary and then an escalation of those items, and I think that may well reflect how the report is presented going forward. But if I can come to the staff governance section now, which is pages 182 to 187, and ask Fiona then Sarah to make comment. Thanks.
Apologies, just getting my microphone off mute there. Yeah, so similar to some of the themes in the other discussions we've had so far, there's a couple of key areas I'd like to pull out from staff governance. Obviously, this section of the report is one that we have a couple of indicators that we consistently report on, including sickness and staff turnover, but we continue to expand the range of other indicators, and the nature of the data means that we will tend to look at these on a less frequent basis, so maybe once or twice a year. So I think sickness absence is an important one to talk about. It has continued to rise, although our percentage absence rate is tracking below the national picture of 5.5%, with ours being at 5.2%. This has increased in the last couple of months. COVID absence has been a little bit higher, as expected, due to the levels that we've been discussing in the community, and that's both related to direct absence and to, I suppose, support for children who are self-isolating more recently. But the reported numbers for that still only peaked at about 100 absences a day, although we do know there are some challenges in delayed reporting, so that's only an additional 1%, so we don't think that's quite right. We've also reported this time on the days lost due to mental health related absence, and we've talked about this before, and that includes stress, depression, anxiety and other conditions. So you'll see in the report that we've looked at how many days lost over the last 3 full years as a proportion to the overall sickness rates, and over those last 3 years it has increased to 9.1% of sickness in the last full year, and for the 3 months till the end of June is 8.42%. Now we know that there will be an element of COVID and the pandemic, and the challenges around that will be a factor in that. We are kicking off our wellbeing work stream from October to help us identify tactical and long-term activity and to develop a strategy around wellbeing. We know that pressures in the system, the challenges of the extended nature of the pandemic and our level of vacancies in some areas will increase our sickness absence. We are continuing to do fortnightly Wellbeing Wednesday emails, and we've had good engagement from colleagues with the Employee Assistance Programme and with our occupational health team, and we've continued to promote the National Wellbeing Hub. And we've actually, through some funding from Scottish Government, just recruited a psychologist to add to our occupational health team offering psychological therapies, and we've existing counselling, CBT and EMDR services available there. And we also have our chaplaincy service, which offers a valuable reflective practice service. Turnover has also continued to increase, although against the backdrop of a previous sort of 2-year fall, quite consistently in turnover. And obviously there is an element that it has been during the periods of lockdown, it will have been artificially low due to people's inability to move. We are focusing on key areas to support under pressure services, and we are continuing to see people interested in and moving into the area to take up work. We're developing our recruitment and attraction and retention strategy, and our workforce agenda will also feed into both the NHS Highland long-term strategy development that will be being discussed later, and also into the national workforce strategy that's underway. We've got around 80 newly qualified nurses starting in October across the board area. And as Pam mentioned, we've got our first always on nursing recruitment advert out. And that's all about maximising the reach of our advertising and having a centralised process for interviewing so that we can free up capacity and make the candidate experience better. So once we've fine-tuned that, we'll roll that out further to other key vacancies. It's also worth noting that we have also welcomed many new senior professional and operational leaders in the last 2 months across nursing, midwifery, HP and medical, as well as in strategy, transformation and acute services following earlier successful recruitment. So we've also included grievance and disciplinary information, and we should have a more detailed breakdown around the timescales for cases to resolve in our November data. And we are seeing relatively low levels of new grievances coming through, but the implementation of the Guardian service has meant that we do have another route for concerns to be quickly raised and addressed, and we've had over 200 of those in the first year of the Guardian service from August 2020. So I'll now hand back. Thank you.
Thanks, Fiona. That was really helpful. Sarah, was there anything else you would like to add from a staff governance point of view?
Thanks, David. I'll try not to be too repetitive, just to really emphasise to the board the importance of that mental health related absences, and I think that's going to be really key in helping us support the work that we're doing on the wellbeing stream, is understanding that data and digging into it a bit more. And just to pick up there on the turnover and recruitment and vacancies, which we know is a pressure, just to say that actually at the last Staff Governance Committee we had a fantastic presentation from the medical education team, and some really innovative work happening in there, especially throughout COVID, that is supporting that overall picture. But that's all I want to add. Thank you. Thanks,
Sarah. That's helpful. Maybe one observation, perhaps. I don't know if I'm supposed to be asking questions here or not, Chair, but separating out in terms of staff turnover and particularly staff leaving, retirements from moves, if I can describe it that way, might be an interesting way to look at it. So potentially preventative leavers versus not. And I recognise there are some interventions in terms of retirement, but nonetheless that's a personal choice that people can make. Okay, I'm going to come now to finance, the finance section from pages 188 through to 192, and Dave Garden, if I can hand over to you, and then back to Alex again.
Thank you, David. Okay, so the IPQR gives the financial information at month 4. So I'm going to assume that everybody's read that, and I'll take any questions on the paper, but I'll maybe give an update on the month 5 headlines because it's more relevant data. So the challenges remain the same as they have been all year to date, in that we've got some uncertainty around funding. We've got overspend running, particularly in our acute services. And as a result of people being really, really busy, we've been unable to progress savings to the level that we have anticipated at the start of the year. So The overspend that's shown in page 188 right now is increased in month 5 to £19.2 million. Now, that assumes, of course, that we'll get funding for a range of things, and there's uncertainty around other things. So, for example, our savings delivery or under delivery, sorry, of around £11.9 million, we're assuming will not be funded, but we're awaiting guidance from government as to the national impact of that. Obviously, that's funded, then our bottom line will improve as a result. Similarly, there are one or two things that were asked for as part of our remobilisation plans, for which we haven't had any funding confirmation, but we have incurred expenditure. So we do have a lot of kind of plates spinning right now in terms of understanding our different funding streams. And that'll become clear, hopefully, after Q2 returns into government, we hope, or a bit more clear, if nothing else. As I mentioned at the start, the overspends increased to 19.2. That is really split into two numbers, effectively. There's £8 million of pressures in the system and £11 million, as I said, of undelivered savings. That assumes funding for COVID. Now we're assuming 36.7 million funding for COVID as it stands right now. The two biggest areas of expenditure there relate to the vaccination programmes for both COVID and flu of £9 million, and also our contract tracing and our testing, which is about £7 million. So fairly significant amounts of money included within our current position around those things, for which we're assuming funding will come. We're also assuming funding will come for the pay uplift that the government have announced, and that includes the Agenda for Change uplift and the slight revision where some of the higher graded Agenda for Change staff increase was in line with the rest of the Agenda for Change, whereas initially it had been capped, and with the medical pay uplift, which was recently announced as well. So we haven't got certainty around all of those different areas of funding, and again we're awaiting government confirmation around that. In terms of the actual overspends that we're seeing right now, as I mentioned already, the majority of those are within the acute services. £6.4 million of a forecast overspend within our acute services at the end of the year, which is split £4 million within Rigmore and £2.3 million within our RGHs. And again, all those numbers will be scrutinised through the Finance Performance Committee at its next meeting. The only other thing to mention, I guess, right now is capital. We've got a fairly major capital programme, as everybody knows right now. We've got the National Treatment Centre, as well as the hospitals in Badenoch and Skye, and between those three programmes, we've spent £14 million so far this year, and our capital. Remaining capital expenditures primarily on equipment replacement and maintenance programmes of around £2 million. And again, we're forecasting a break even on capital at this point in time. And we're also in discussions with government around our capital plan for current and future years as well, which Alan Wilson's leading on. I'll stop there, David, and any questions at the end, I guess.
Thanks, David. Before we open it up for questions across the various sections, can I just come back to Alex if you wanted to add anything from the finance point of view, Alex?
I mean, the numbers are there, but I think I would like to emphasise the amount of good work that's going on by the finance team, the PMO, and Alan Wilson's team in estates to make sure that we're keeping a handle on it. We're trying to do as much as we can in this very trying time with COVID. Our target savings, I'd be very, very surprised if we get there. And I think that's something that we need to recognise now. But it's not for the lack of effort, far from it. And I think it's something that we should record at this point. A big thank you to all these teams that are working very hard to try to get the savings, even though we recognise that the chances of making it are very slim. Thanks.
Thanks, Alex. So Boyd, that concludes the run through. I'll open it up for questions now. I think, Graham, your name is first on my list at least, so if I can work through that, that'd be fine.
Thanks, David. Thanks for a good presentation. Enjoyed that. I was just wondering, just a general comment about cancer treatment. A local colleague in Cardross, his wife was diagnosed with bowel cancer about 6 months ago, but I mean, I spoke to him just last week, and he said the general care and medical care was excellent. So that's good news. And just a general comment or question for Fiona. You mentioned in the welfare wellbeing program that there's a chaplaincy available. I was wondering if there's any other availability for other faith denominations. Thanks.
Yes, thanks, Graham. Yeah, so I suppose the chaplaincy service, and I'm sure Heidi can speak more about that, but it is very much a sort of non-denominational, open to everyone's service, and that and actually some of the things like the implementation of values-based reflective practice, working with teams to help them. I think when we talked to some of our intensive care staff a few months ago, they referred to that as well. So I'm not as close to the details of all the services provided, but certainly from what I understand, it is accessible to all.
That's great. Thank you, David.
Thanks, Fiona, and thanks, Graham. I think we were reminded at the beginning of our session today that at the end of these numbers are people. And the people experience is so important at the end of this, and I think you've just brought another example of that, so thanks. Alistair Christie.
Yeah, thank you, David. Several points. I'll give you them all, and then perhaps David, you can decide how to deal with them. I think it really is pleasing to see the 31-day cancer statistics and the review of that, and excellent work has obviously gone on with the teams to actually address that. And turning to the 62-day cancer, obviously improvements been made across April, May and June. It would be interesting to hear from Catherine what the trajectory is on that, because obviously it's some significant jumps, especially from May to June, as to what the trajectory is on that of achieving the targets or getting closer towards the target. The next point is probably to Boyd in terms of the adverse events. If you look at the adverse events numbers for April, May and June and take that as a trajectory and multiply it up, it is going to be more than the total number for 1920. I can't read the graphs. I can't tell if there's any seasonalization to factor into this, but it's just a question, is there any concern or reason why the trajectory should be running at a higher rate? I really welcome the mental health analysis on the data of days lost. I think that really is useful and helps address it. And I think as we move through these COVID times, when we know, and we heard in the presentation this morning, how difficult and how stressful it is for staff, I think it's a really important statistic to be capturing. Final point is on the finance. Alex was saying that the target savings are very difficult to achieve and slim chance of getting there, and I agree with that. So my question is, what conversations have taken place already with government to alert them to the fact that the savings targets for 21-22 are difficult to achieve, and what was the outcome of those discussions? Thank you.
Thanks, Alistair. We'll just take those in turn. Catherine, I think you just alluded to it at the end of the conversation, but the question around the 62-day target or performance trajectory.
Yeah, what I can tell you, I don't obviously have the position for September, but for August we actually made the target, so we were 85.3% for August.
That's great. And I think just to add to that, the other thing, just for context, there are certain treatments that we are relying on other boards to provide for us, and their challenges that they have around capacity, flow and scheduling will also have an impact. So I think that's been a great focused piece of work by the cancer board and the team that support them in terms of that recovery. So thanks, Catherine. Boyd, if I can come to you around adverse events.
Thanks. So the stated figures for adverse events, so things that have come in through the DATEX system and been alerted, etc., was just shy of 12,000 for 2019 to 20. And the 3 months quoted show numbers that are just under 1,000. So if you 19 to 20, it was about 1,000 a month, in other words, and the 3 months that have been in this version of the report, it's just under 1,000 and then about 1,100 in the other two. It's difficult to say that's a trajectory based on 3 months data, but we do know that those particular months there was a real surge in activity as services opened up, and at the same time we saw the public start to come out, and lockdown had ended and all of the social measures had dropped. So it was an increase in clinical activity and also an increase in societal activity. I guess we probably have to look at longer term figures to understand. It's complex as well, as adverse events are dependent on reporting, and many things affect the reporting levels of staff. So you assume that 100% gets reported, but we know from real life data and experience that you don't get 100% reporting on everything. We don't, therefore, we're not able to say for sure what 3 months figures really mean, but we do watch the trends and look for that. We did see, I think, a downturn during lockdown periods. There was a difference in the numbers and the type of reporting. And now that we're in what is a very busy 2021, I expect as the data emerges across the whole of this year, we'll see some novel patterns that we haven't seen before, because we know that having had the comet of the COVID hit us, we're now in the comet's tail with quite a long runoff and a lot of new phenomena that are complex and hard to understand at this stage. So we'll keep an eye on it, but I'm not sure we can draw conclusions yet, and certainly not from 3 months as a pattern.
Thanks, Boyd. And finally, Dave, in terms of projections and discussions with government with regard to finance?
Yes, so we've got within our COVID return, our Q1 COVID return, we've included an expected underspend on under delivery on savings, and we'll include that in Q2 along with other boards as well. So all boards that are have undelivered savings have included that. We've also had discussions with government directly in terms of our finance Q1 review, where we went through the details and you know, as Alec mentioned, we took the government through the work of PMO and all the things that we're going through, and to reassure them that we weren't actually we haven't moved away from principles. It's just the fact that it's really a really difficult time right now, and I think there's a general acceptance of that, and also there's a more informal discussion with Richard McCallum from the Scottish Government on Friday, where again we touched on the under delivery of savings as well, although there was no outcome for that meeting. It was just keeping Richard up to date until the government make an announcement in terms of whether or not they'll fund that. We don't know, but we're keeping them appraised and including it in our forecast until we get certainty.
Thanks, Dave. Catherine, did you want to add anything to that? I saw your hand go up.
Yeah, I just wanted to come back into Alistair just to be absolutely clear, and so that the board is absolutely clear on what I have said. On page 146 of the IPQR on the S-bar, you'll see that for August we were 85.3% on our 62-day standard. The national performance is 83% against that standard. We continue to work to deliver a 95% standard, which is the overall national standard that we're working towards. Just to be absolutely clear in terms of that response. Thanks, David.
Thanks, Catherine. I'm conscious of time too, but Bert, if I can come to you.
Thanks very much, David. A couple of questions for Boyd, please. Firstly, in relation to the serious adverse event reviews and the narrative in relation to the current challenges, where it says, it's just to clarify what's being said there, to ensure that staff across the organisation report adverse events, and maybe Boyd has already alluded to that in his earlier response. I think it was to Alistair. So does that mean that not all adverse events are being reported, and therefore the numbers that are shown, particularly in relation to the serious adverse events, are higher than which we are actually reading there? And then also in the narrative, to ensure that adverse events and events that fall under the organisational duty of candour are investigated in line with policy and procedures, just some assurance that we are following policy and procedure. And the second aspect is in relation to complaints, and I note the figure is 24% at June. It might be different now. The aim is 70%. And we've talked previously about the challenges that there are in reaching these targets, but getting from 24% to 70% seems to be quite a big ask. And I just wonder how realistic that aim actually is. Thanks very much.
Thanks, Boyd. If we can look at those two items briefly, that'd be great. Thanks.
Right. Yeah. So, in terms of the numbers report, I think the version that comes to board is slightly behind, as you point out, and things are moving on. And I know that there's been an update in that section since. In terms of the numbers reported, it's a human factor issue, really, that you never get 100% of anything, and so you have to constantly monitor and make sure, and you do occasionally find something that you think that probably should have been reported, but it wasn't. But you equally get large numbers of sometimes smaller adverse event things, quite small things reported in, so that changes the numbers. In other words, it's a system that is subject to a lot of different variables, and what you want to do is monitor and make sure that where any serious event occurs, those especially those we get 100% reporting on. It'd be unusual for one to slip through the net, but just occasionally that can happen, and you discover it later through another process. So they do get picked up. How do we measure the things that we don't see? I guess, as I say, they eventually do surface if it's a serious one, and for a lot of the volume, they're the lower level adverse events that are within much of the volume, and that can vary a lot depending on all sorts of factors. In terms of the systems assurance, then we have quality and patient safety meetings which go on, which use the likes of Datex and other sort of information sources to make sure that things are gone over, and also to raise awareness among staff of the importance of when something doesn't go as planned or has an adverse issue or outcome, that these things are harvested to be used for organisational learning and improvement. And so that's a continual thing that's always running, and you can always do more. For complaints, the 70% is an extremely high target, and I think that looking into it at the moment, some of the strain is in COVID concerns and COVID complaints. Now, the concerns aren't measured in any of our metrics, but they take up a lot of the team time. And as described to me this month, a concern involving, say, COVID, concern about vaccination, or a complaint about I haven't got my vaccination yet, requires 4 different handoffs within the organisation, because it has to be passed and communicated to a variety of different departments or professionals or elements of the service. In terms of some of the other issues that fall into complaints, the central corporate function handles the complaint, sends it out, but then the element where the complaint's looked into and a response is formulated, that then takes time, and we've found that in the pandemic that time has increased because people are busy doing the clinical services directly at the time as well. And so we need to find a way to counter that competing demand, and that's another issue for us. And it may be that requires resourcing both centrally in the corporate team, or it may require some bolstering of what there is within operational units to be able to deliver. And the last comment I'd make about the numbers is that this is a metric about getting a response within 20 working days, which we're not meeting. But probably, while that's very important, it's set as a government standard, the quality is an important element too, and we need to make sure that we, in improving the time to get the response, we are not we need to maintain and improve quality always. So there are some things that don't have an easy metric and therefore not reflected in this report. But things like quality and accuracy and checking with multiple involved clinicians or elements of developing a response all come into it. This adds time, unfortunately, and it's a balance about how much you can put that together and get as much together as possible, and the thoroughness of it versus the timious element of it and getting it across sort of an external metric around time. So there's a bit of a balancing act. So 70% is probably a very difficult target to aim for, and at the moment we are nowhere near it.
Thanks, Boyd. I mean, clearly there's work to be done on that, but again, it's a balance between the thoroughness of the response as well as the speed of the response, and sometimes getting the right balance, and that's why the targets may not necessarily be the best as they stand. I'm very conscious of time. Maybe if I can take comments or questions from Adam, then Anne, then Alex, and then we'll collate the responses if that's okay.
Thanks, David. Thanks, everyone. I'll just restrict myself to one question then, which was about your some of the background information, David, you were giving about outpatient waiting lists and so on, and the challenges around that. But generally, with the demands now facing the system as a whole, really, just looking for assurance that we're not kind of pushing things so hard that this impacts then on staff health and well-being, because obviously, you know, without the staff that are able to do the job, we won't have a service at all. So I'm just wanting to, as I say, seek assurance that we're not placing too many demands on staff to achieve all the targets and all the waiting lists and all the things that need to be done. You know, many of which are of very significant importance. But we need to manage it very carefully in terms of demands on staff.
Thanks, Adam. I'll hold on to that and collect the others first. Anne Clark.
So I don't think any of us being after reports of the work that's being done in adult social care. I think that I wanted to ask David Garden, first of all, how significant the fact that we managed to achieve an agreement with the council over allocation of risks in relation to the adult social care gap was this year. Whether I'm correct in being concerned that it looks like we're going to have a very significant pressure next year from the additional adult social care demand that we're experiencing, which is currently being funded by COVID costs. And in relation to that, what discussions have we had with the council about agreeing a position for next year, and what response, if any, have we had so far? Thank you.
Thanks, Anne. So in terms of the current year, you're absolutely right. The position for the adult social care costs were effectively underwritten by some money from government, £4 million from government, and a commitment to provide £2 million from both of the partners, ourselves and the Highland Council, towards the gap. So the starting gap was £11 million, and £8 million of funding was put towards that gap, leaving a savings challenge of £3 million. And we're currently expecting that we will probably deliver that £3 million either through direct savings or through some underspends in areas that haven't remobilised through COVID. So there certainly is an issue there, and as you rightly say as well, there's also some expenditure on the social care through COVID, which has been funded directly by government COVID funding as well. So moving into next year, the position is very, very challenging in that all the partnership contributions effectively were non-recurrent resource, and a significant proportion of the savings or underspends are non-recurring resource. So we face the danger right now of going into next year with a position that's starting off worse than the position was in the current year. And it could be as much as £12–13 million of a starting gap next year. We are in discussion with the council around that gap, and there's been no conclusion yet as to how that will be addressed going into next year.
Thanks, Dave. Adam, I haven't forgotten about your question, but let me come to Alex first. Anything from yourself, Alex?
Yeah, very quickly, David, thank you. Boyd, the freedom of information requests, they're steady, they're 46, 42, 50 per month. And the response to that seems to be improving. We're up at 70% or whatever it is now. But what I don't see and haven't seen anywhere is how much that actually costs us. I don't know if it's yourself or Dave, somebody can give us a number so we can actually see how much time, effort and money that the board is actually spending on responding to the FOIs. And very quickly for Catherine, what I forgot to ask was, how's the robot doing, and how many operations have we used it on since it's been brought into operation? Thanks.
Thanks, Alex. Okay, if I can go back to the first item that Adam that you raised around staff wellbeing. I think there's two points to note. When we are looking at our plans are made with the services in terms of our remobilisation plans and how we remobilise. So that it is very much part of a discussion with the services as to what they can achieve within the capacity that they have. And obviously, as we have to reprioritise, we do such. And I think the fail-safes that Fiona highlighted in her report shows the level of support that we are giving to staff, so that staff are supported in being able to deliver services, whether they be scheduled or unscheduled. So it is a balance within it, and I think we are taking a balanced approach to it. And of course, the most important thing for us to do going forward is to continue to listen to our staff and our teams and the feedback that they give us, so that we can adapt and be better supportive of our teams, and indeed then that will deliver better results at the end of it. And I think that's well recognised across our services, but it's absolutely fair to raise. In terms of FOIs and the other actually area is subject access requests, Alex, which is a growing industry, I would suggest, across our organisation between FOIs and SERs. And it's probably not something that I'm aware of that we have collated in terms of financial terms, nor in terms of the number of hours that it takes to support. But let's just say that we've had to introduce software systems to try and control the amount of requests that we have that are coming through the system. It is mandated that we support these areas, but I'm happy to take that offline and feed that information back to see if we can collate a number or get close to it. So I'll leave the final part, if I can, in this section to Catherine to talk about the robotic surgery, if you want to add anything with that, Catherine.
Thank you, David. So the robotic surgery is going very, very well. We have already commenced operations. We've been doing training on there, and our surgeons have been using it. And indeed, there have been positive reports from patients that have been through that process, and it is helping us to get patients home faster than we would normally be able to do, and that's the fantastic thing about the robot. In response to your precise question of me, Alex, I'll have to come back to you on that to tell you exactly how many operations we have done now, but I can tell you that the service has commenced, it's ongoing, and it's valued. Thank you.
Sorry, I see one further hand up before I hand back to you, Boyd. Graham Hardy.
Yeah, thanks, Dave. Just a quick question for Boyd. It's interesting when you're talking about complaints. It's just out of interest. Obviously, when you make a complaint to the bank and you're not happy with it, I think you go to the financial ombudsman with them, the financial authority, and then if say in planning, if you're not happy with a planning decision, you appeal to the Scottish Reporter. I was wondering within the NHS if there is some system in place where if you're not happy with a complaint or how long it's taking, where there's an outside body or an independent body that would take up your appeal. Thanks.
Yeah, I can answer that. So there is where just like exactly as you mentioned, there's an ombudsman for the NHS complaint system as well. And so a small number of our complaints, usually the most serious ones, that will go to the ombudsman. And the benefit of that is that it will offer an independent opinion. And sometimes where a complaint response, the content of it is not, the complainant is not satisfied by or in agreement with all of that, they will use the SPSO in order to get someone else to review the complaint and the complaint response. So there is a system is the answer.
Thanks for that. Thank you.
Boyd, if I can hand back to you, apologies for going over time, but it was a really helpful conversation for me and lots of good questions from everybody, and thanks for the engagement on this section.
Thank you, David, for conducting that session and for all the very good contributions to it from members. Just before we leave this item, I'd just like to thank David and his team for the work that you're doing and taking forward in refining the IPQR, both in terms of content, in terms of format, and indeed in terms of governance. And that's a continuing process, and we'll see a further form of the IPQR future meetings. But thank you to yourself and your team for all the work on that front. And one just observation before I leave the subject is that the link between investment and performance is very, very clear in terms of the urology centre, the additional endoscopy centre, endoscopy room, and indeed Alex's robot, if we can call it that. A clear link that the more we can invest in facilities, the performance will be improved as well. I think that's something we have to bear in mind when the Cabinet Secretary makes asks of us in any particular subject area or specialism. Okay, we're somewhat behind schedule, but let's soldier on. And the next three items are all to do with culture. And I think Fiona is going to be front and centre of these items in presenting them to us. So first one is the update on the culture programme. Fiona.
Thank you, Chair. So I'll just do a short sort of summary of some highlights around the culture programme, and then we can cover any questions on that item. So we are making really good progress with the culture programme. Although at the time of producing the report a few weeks ago, we were reporting amber, we are now trending towards green overall, with the Leadership and Management Development Programme now launched for registration for levels 1 right through to 4. And so we're signing up our first cohorts of up to 90 colleagues for this modular programme. We've also agreed the content for the first team conversations, exploring our shared values sessions, and that's been a collaboration between 3 of the work streams, and it's taken quite some time to come up with the right content for that session, but these are now being set up for the first sessions to start from October, and we'll continue with evaluation and fine-tuning of that as it's rolled out to the first teams over the coming months. We do continue to review and act on the listening and learning survey results at a local team, division and organisational level. We're really focusing on the conversations and what these are telling us and how we want to address them. And we've also just received our iMatter reports, so we'll be addressing those together. We're planning a report on both surveys to come to staff governance in November, and then we'll do a summary of that to board next time. We're now working on the next elements of design for our culture programme. 2 of the key areas are that we're investing in wellbeing, as we just talked about, with the development of our strategy and plans as part of a work stream in the culture programme. And we've got a lot of focus on this over the coming 6 months, with dedicated resource being put in place as well. The other thing we're really keen to progress with now is implementing the Civility Saves Life work in some way across the board, and we've talked about this at board previously. Most recently, we've been discussing this with Professor Jerry Hickson of Vanderbilt University, and he developed the research behind this. So we're working with our workstream lead, Helen Freeman, along with key stakeholders to put in place some plans around how we want to roll this out. This is a really important part of our culture programme because it's not just about behaviours and relationships, but it also shows us about the correlation to patient safety and patient outcomes, and the need to create a safety culture that focuses on psychological safety, trust, and the power of peer-led conversations and early resolution. So we're really keen to be moving that forward. I think the final thing I'd just like to say on this is that despite and perhaps because of all the pressures that we've described so far today that we continue to face as a health and care system, it's even more important for us to continue to progress our work on culture. We know when things are pressured, behaviours, kindness, civility and relationships become even more important. But we are taking a balanced approach as well to the rollout of initiatives, and we will make sure that we land these in the right place and that colleagues have the capacity and space to engage with them. So I'll hand back to you now, Chair, for questions.
Okay, thank you, Fiona. And are there questions for Fiona on item 8.9? Adam.
Thanks, Boyd. Thanks, Fiona. I just actually wanted to draw a very quick parallel to the presentation we had right at the beginning from our colleagues in the COVID response team, who talked and I kind of jotted down some of the words that they said about trust, about together, support, team, and I think it was clear that none of them could have delivered the service they have without that kind of feeling around them of support and togetherness and team working. And I think that's just a super example, obviously, of the culture we want to get to everywhere, and that Fiona's just outlined very quickly and also presented in the papers. So, as I say, I just wanted to make that link and recognise the value of the culture in that team and how that's contributed to, you know, an amazing service being provided, and how that is very much the culture we want to be seeing everywhere.
Okay, thank you, Adam. And we have Sarah and Anne. Sarah.
Thank you, Chair, and thank you, Fiona. You'll be amazed that I keep coming up with questions despite having probably seen this update a great many times. It's about the Leadership and Management Development programme, which I'm really excited to see moving forward. I think it's going to be a really positive thing for this work. But I do have one question about how we're going to maybe track who's taking part. So obviously the kind of the first round, we've got people will nominate or be nominated to take part, and I recognise it will be a rolling programme, but I'm thinking maybe sort of a year into the future, when Staff Governance Committee come to look at this in detail, how will we be tracking who has and hasn't taken part? And I suppose the second part of that question is, how are we going to capture the people who haven't taken part? And I suppose I'm thinking about particularly people who might have been in a leadership role for a length of time and might perceive this as being a tool for people who are new leaders, or who maybe their learning style doesn't sort of resonate with the package. So how are we going to capture that to make sure that we can deploy this tool as widely as possible through the organisation? Thanks.
Oh, you're on mute, Boyd. Sorry.
Well, thank you. Maybe before you respond, we'll bring in Anne and Alex.
Yeah. So actually, my comment is on this subject as well, and I've only had a chance to have a quick look at what you sent round, Fiona, but I think it looks fantastic, the information on the management development programme. I think it looks like a really well thought out framework for the development activities. So I just wanted to give you that feedback, but also to ask, I'm sorry if I've missed this somewhere in the papers, whether there's any opportunity for people to get any accreditation or recognition formally, whether we could develop anything like that with UHI or anybody nationally, for example, so that people could get some wider value. But it looks like an excellent piece of work, so congratulations. Thanks.
Thank you, Anne. Alex.
Yeah, thanks, Blake. Yeah, thanks, Fiona. A couple of things. One, a suggestion to help, and the other a question. As usual, I kind of focus on milestone dates, target dates, etc. Most of those aren't achieved. Well, some of them haven't been achieved. What I haven't seen yet is what the new date is. So perhaps what I've seen before is you put the old date in brackets and then you put the new date below it. So you've now got a target that we know, rather than saying, well, you've missed it. Yeah, but what's the new one? The other question on the leadership and management bit, to build on what both Anne and Sarah said, we're continuing to try to progress with mandatory training and the percentage of that being achieved. Is there an intention to make some of this mandatory training for leadership? Because I could see a benefit in doing that in the future, not necessarily today, but certainly in the future. Thanks.
And one more contribution from Bert.
Thanks very much, Chair. I would just echo, I suppose, all of the comments that have been made so far. I think this is a really valuable tool. I'm really pleased to see this being introduced. I think it's got so much potential and so much opportunity to support and develop staff. And indeed, when we talked yesterday, the particular point that Alex made there latterly about involvement being mandatory or otherwise, I think is a really important consideration. I think it's something that we need to monitor as we go forward to see what difference this is actually making to things in relation to culture. I think it's an important part of the whole culture agenda. One question I've got is, what participation will there be in the programme from existing leaders? And I suppose I mean people at an executive level where I think there is an opportunity to set the tone, to set the standard, to set the direction, and to get things to get things in the way that we would want and expect them to be in place. Thank you.
Over to you, Fiona. You got a good memory.
I've been frantically typing so I can capture everyone's questions because I can't always read my own writing. So I think starting back at Adam's observation, and I think he made a really good point about the team that we saw at the beginning of the meeting today, and that real sense of trust, togetherness, and sense of team. And we've seen that actually with the other teams that have come and talked to us. I think intensive care, that was a really strong example of that. And I think what that reminds us is that the things that really bond a strong team are a shared vision, shared values, and a strong sense of purpose. And that's really one of the reasons why we've done the work on that team intervention that I talked about really helping teams to articulate what those shared values and those shared purposes are, so that they can kind of strengthen and build those relationships. And it really is at the core of people's experience of work, those people that you work next to day in, day out. So I think it's a really good example of what we're looking to achieve. In terms of Sarah's question and feedback, and I think all of the really positive feedback about the Leadership and Management Development Programme is much appreciated. The team have been working incredibly hard to pull together all the content and the logistics, and to have a programme of such a kind of range covering 4 separate levels of everything from kind of introductory supervisors right up to level 4, which is kind of senior management level, and all the different types of content. We're at phase 1, but we'll continue then to roll out other content as we go along. In terms of tracking who takes part, so the first phase for 1 to 3 is about self-nomination, and what we will do is monitor the take-up across different levels, across different professions, across different locations, and obviously as we move into a second cohort, what we'd certainly look to do is to sort of target kind of take up of the course into areas that aren't represented. I think the other piece there for me is about this should be an integral part of our work towards having every colleague having a regular series of one-to-ones, talking about their performance, talking about their personal development plan as part of an appraisal system. And that's really how we capture those needs, whether that is at kind of a kind of more experienced manager level, or whether it's about capturing people at a sort of aspirational supervisor or leader. One thing I would just point out is that the level 4 cohort isn't self-nomination. The kind of executive and senior manager team have been asked to consider and nominate for the places on the level 4 cohort. I think just to ensure that there's that's profiled appropriately. Again, in terms of Anne's comments, we will absolutely be looking at opportunities for accreditation. Previously, we have run a sort of small cohort using the Institute of Leadership and Management framework, but actually that hasn't been able to be offered. But we're certainly keen to make sure that we have that, whether it's about formal accreditation or kind of recognition. And we're working very closely with the University of the Highlands and Islands generally, so it's definitely something for us to look at. In terms of Alex's points on the milestones for the plan, we're actually currently underway with the sort of next phase of the plan and any sort of replanning date. So we'll definitely take that comment on board around being able to model the kind of old dates against the new dates. And I think that's really helpful information. And you'll see from, despite the fact at the time we produced this last report, we were fairly confident that we were going to deliver the particularly leadership and management development and team interventions. We were quite keen to be conservative and report on amber until such time as we delivered it, given we were just a slightly behind plan. So we'll work on that. I think the point around mandatory training is a good one. And I think, as you say, in the long term, my aspiration would be that every individual who is preparing to take on a supervisory role would have, kind of that training before they take on role. And if somebody joins us in a leadership role or takes up a leadership role and hasn't had that opportunity to be trained, that we would want to be doing that. So I think it is, for me, it is really important. We obviously have a bit of a backlog that we'll want to prioritise and get through, but for me that is absolutely, you don't get to have a go at driving a car before you've got your licence. So I think that for me is an important aim for us to have. Finally, on Bert's points, the participation in the programme from the exec and existing leaders, absolutely, that's something that we are making sure that we build into, actually not just the management and leadership development programme, but also into the team interventions, the team intervention kind of values workshop, there would be a sort of video introduction from Pam. In terms of the leadership and management development programme, we'll absolutely want to have regular engagement and involvement, obviously sort of from myself as Director of People and Culture, but the wider exec team. And we've also got quite a lot of our senior managers involved in actually developing the content and delivering some of the content, particularly around our specialist modules when we get to that level, like health and safety and risk and other areas like that. So that's definitely something we want to make sure. And some of that is it's about us being able to tell our own stories as well, because each of us as leaders have had a journey to get to where we are. We've probably learned a lot along the way and picked up experiences and not always, known everything that we needed to know at the time. And I think there's something incredibly powerful about being able to share those stories so that people know it's a learning journey, and we're never quite the finished product.
Thank you, Fiona. And just before we leave this item, I just want to emphasize the importance of measurement and metrics and all of this, how things are landing, how things are impacting. And I think we do well to adopt a citizens panel approach to the follow-up to the listening and learning survey, and having a random sampling of our workforce to test the temperature of the organisation going forward at regular intervals. Can we move on now to the healing process and the update on that, Fiona?
Yes, that's fine. I'll just switch back into my notes. Okay, so yeah. So the healing process obviously is a unique and bespoke process that we develop to support people to gain closure and move forward. And an important element of that was to be as independent as it could be. And the external support that we put in place for this has allowed the process to continue throughout the pandemic, which wouldn't have been possible if we'd internally resourced this. And it's also given 293 participants in total the confidence to be able to access and work through the available support. So as you know, the independent review panel makes recommendations for action based on what they will feel will aid healing, having listened to participants. And today, NHS Highlands has supported all of their recommendations, whether that's for psychological therapies, apologies, financial payments, as well as taking on board the organisational learnings. It's important to reflect that the nature of the process is that it hears the participant's perspective and account only. It doesn't seek to allocate fault or blame. So it's an entirely different experience to internal processes or to external tribunals, which have to seek to establish these things. Our process is all about healing and working out what will best aid that process for the individual involved. So our report notes that 177 participants to date have completed the process, and we've 116 still working through that. It is positive to note, and picking up on a theme that we've already talked about around mental health, so many people are being helped by the provision of the psychological therapies that we've been able to offer as part of their recovery journey. And that was always a really important aspect for us to be able to offer. You can see from the report that over 205 participants have taken up that offer. That can be ranging from support calls, assessments, and a range of therapy from brief counselling, extended counselling, wellbeing sessions, to more in-depth therapies like CBT and EMDR. Because we use Validium for our employee assistance programme, which charges us a cost per employee per head, where a current employee is recommended a treatment that's included in the EAP, there isn't an additional charge. In terms of the apologies, we have 85 apologies personally written by the Chief Executive and issued to date. A further 10 had requested apologies, but the panel didn't recommend that those were appropriate in the circumstances. We've had 2 organisational learning reports presented to the board in May 2021, and further reports are presented as new issues and learnings arise. We're expecting the 3rd report to be presented at the November board meeting. And we have committed that a final board report on the overall process will be prepared once all cases are heard. We're currently expecting panels to last into March 2022, so it will probably be around June, July 2022 that we have that final report. NHS is fully committed to learning from the healing process and to making sure we can do all we can to be a great place to work, and we're tracking all of the actions from those organisational learnings through our culture programme. In terms of costs, we have been reporting the costs and payments in the last financial year, which are part of our annual accounts that are usually released a bit later in the year. However, in this paper, we've provided the latest position, which includes those cases that were approved at the Remuneration Committee on the 9th of August. The costs around the process include the setup of the process, and that required a significant amount of external advice, including legal advice. As we said before, this is something that's never been done before. That work took many months in late 2019 and mainly into early 2020. And these costs also cover all of the running costs of the process, including the panels, the administration, the advisors, the psychological therapies, setting up and running the website on which all the information and access has been based. And as I mentioned, all of those were externally supplied because that was what was needed to ensure the process could be trusted by those who had been harmed. So we reported that 1.1 million was spent on setting up and running the healing process in the last financial year, and that was funded by Scottish Government. And it's expected that the costs for this financial year will be in the region of 1.282 million. And again, that funding has been provided to us by Scottish Government. Specifically in terms of the framework, the payments, there is a framework for payments that's been agreed and published on the Healing Process website. And that's what the independent review panel used to determine the awards. All 150 payments which they have recommended following panel hearings have been approved by our Remuneration Committee. The IRP don't agree all requests for payment, and there have been 27 cases that have either not asked for payment or have asked and not received payment. As noted in the annual accounts, we accounted overall for current and future liabilities of the payments of 4.2 million. That was at the point in March. We thought that was the kind of best estimate of a figure based on the number of people to go through the panel and the cases we'd had through so far. To date, 2.063 million of that has been approved for payment. Based on the payments to date and the cases remaining, we continue to reforecast, and the current modelling suggests that the total cost of payments would be in the region of 3.415 million against the original sum that we provisioned for of 4.2 million. So I'm happy to hand back to the chair for questions.
Thank you, Fiona. Any questions on the report that Fiona's presented? I suppose one element that we don't have in the report, Fiona, is the feedback from participants in the healing process on the success or otherwise of the process for them personally. And I think that at some point in the future, towards at the end of the process, we should try and capture that. I think we have anecdotal feedback from individuals who have had positive experiences coming through the healing process, which we have to remember is one of the major planks of our programme to address the findings of the STOIC report. Any thoughts about that, Fiona?
Yeah, and I think in our update previously, I think in May, where we presented the first two learning panel reports, we did have a little bit of feedback included there. So the independent providers continue to collate metrics and reports and feedback for us. So it's something that would definitely feature in the final report. But actually, I think if we're bringing back a learning report again in November, we could provide a summary of both the kind of metrics and also maybe some of the anecdotal feedback, because that is captured as well. So happy to do that for the next meeting.
Yeah, thank you, Pam.
It's probably worthy adding that, you know, with having the privilege of doing the apologies and access to some of the stories, I have a probably deeper I suppose, understanding of some of the themes and some of the personal stories. And in that, for me as a chief executive, that's been invaluable in starting to really understand the depth and the breadth of what we need to be considering in all the work that we're doing, and how we need to be in this organisation, all the way back to how we actually deploy positive leadership and good transparency and open and with an ability to speak up within an organisation. So you know, it's really a privileged place for me to sit, and it's hugely valuable to have access to that information. I do have direct feedback from individuals, and I would say that I've had by far the majority given a very positive feedback, but it's also fair to say that for a small number of people that have been in contact with me, and it has been single figures, that for some people they haven't felt that it's assisted them, and we just need to be cognizant of that for those individuals who have not had that experience, and that's disappointing. But I guess as with any programme, we may not be always able to address everything for everyone in that programme. So I think it's been a huge piece of work so far, and will continue to be so, but hugely valuable in sense checking where we think we're at, sense checking that the actions we're taking and our intentions as we go forward are going to take us to the right place, so that hopefully for the majority of people, they do not find themselves in that position again. But we also need to acknowledge that it's a big organisation with lots of employees, and the human factor will always be a factor that we will have to deal with, and we just need to make sure we set that precedence well and have the performance management in and around this to ensure that people are managing to lead and manage in the way that we would wish them to. So it's all related and all connected. There are several parts to this recipe, but it's the single most important thing for us to get right, because it's really important for good patient care that we have a really positive and open and supportive culture. So just wanted to put that in.
Thanks, Pam, that's helpful. Alex, and then Graham Hardy.
Thanks, Boyd. Fiona, thank you. It's going well, it's moving forward, and that's great. The recommendation from the internal audit on the information asset register and the protocols around the retention times, the record retention timescales, how's that going? Because clearly the confidentiality of this process is one of its cornerstones, and we need to make sure that we protect that. Now, that potentially is an area of risk. So how are we doing, and how's progress been made on that recommendation? Thanks.
You want to just take that, Fiona?
Yeah, happy to do so. So yeah, thanks, Alex. I mean, I think we've already had a couple of meetings to discuss this, and we're in the process of developing the information asset register even, and think about our because that's the first step, because that just helps us understand exactly what have we got where. As you say, confidentiality is significantly important to this process. What it does help though is that we have such a small number of people who actually have access to any information, that it does make that a slightly more rapid process. So we're already well underway with that, with support from our kind of specialist colleagues. And then from that, we will develop the dedicated sort of strategy around retention periods and who will retain them. And it's been agreed that it may well be that we have a different approach to the standard way of storing information that needs to be retained because of the sensitivity of it. And our information governance colleagues are giving us really good support with that. So I think we're definitely on track with that.
Thanks, Fiona. Graham.
Thanks, Chair. Just a general comment, Fiona. Obviously, listening to the updates, every day you hear it's getting better and better. And obviously, and you said it's never been done before, so it's in a way kind of pioneering. And just that a general thought that the way we're addressing the culture issues within the organisation and in a positive way, that perhaps in maybe 10 years' time it'll be a model for other organisations that will have to deal with the same thing. So just a congratulations on all the hard work you're doing. Thanks.
Thank you, Graham. That's appreciated. And I think, as you say, we've got a unique opportunity here to really invest the time and the resources and the space and culture in a way that perhaps isn't always possible in other areas. So, but it also places a great responsibility on us then, because actually not only do we have a lot of focus and scrutiny, but actually we have been given some of the resources and tools that other people haven't. So yeah, it's really important to us that we look at this in the long term and we continue to monitor and measure the success of things we do, and if they're not quite working, that we're able to kind of adjust and adapt as we go along.
I think you're right. I think you're right, Graham. I think it is an opportunity for us as an organisation, and it is an aspiration as well for us to be leaders in the field of culture. And indeed, other boards are looking at our experience and how we have handled it, and we'll be looking to take learning from our situation.
Thanks.
Okay, can we move on then to the next item, which is the Whistleblowing Standards Report, first quarterly report. Fiona, again.
Thank you. You'll all be getting a bit sick of me, but I can say this is the last you'll hear of me for a little while. So the National Whistleblowing Standards came into force, as we know, on the 1st of April 2021 across NHS Scotland, but they do apply to all of those delivering services on behalf of NHS Scotland, whether that's an HSCP, an IJB, independent contractors, and also the voluntary and non-profit sector. In our implementation, we've been supported by our Speak Up Guardian service, who, in addition to their standard service, manage a dedicated helpline for whistleblowing for the board, and that ensures that concerns are appropriately directed, managed, followed up and reported by the board, whilst ensuring it is the organisation who are making decisions and dealing with the concerns. So as part of those standards, there is a requirement for us to quarterly report to the board. The first quarter, April to June 21 report is included here, and we would expect further reports to be presented at the relevant meetings. We've also presented this information at the Argyll and Bute IJB and at the Staff Governance Committee. We've tried to make the report as comprehensive as possible so that you've got the context of the standards and the requirements they place on us, as well as how we are addressing them. What I would highlight though is with the first report, we don't have anything to compare this to. So in future reports, as we build more data, we will be able to report on trends, on outcomes and on themes in more detail. And we'll also be able to present views for different segments or populations. But you will just need to bear with us while that kind of data builds. I think it's been really good to see the level of engagement with the whistleblowing standards to date. Having 9 individuals raise concerns shows that we've got good sort of understanding and communication around the standards. although we've always got more work to do in that space. Whilst many of the cases weren't found to be ones that would be managed under whistleblowing, it's been a really good test of the processes and of our systems. As we set out in the report, reasons for cases not being identified as whistleblowing include where they're not related to NHS Highland services, where someone isn't willing to disclose personal details, although we can and do take those forward with the Guardian service instead, and where there are personal complaints or grievances rather than those that fall under the public interest as set out in the standards. In terms of how we handle this, each potential case is overseen by myself as the liaison for the board, and we have input from all the relevant professional areas. And where decisions are made not to take things forward, these are documented and shared. If the case is believed to be whistleblowing, I then work with the key contacts to identify a relevant senior manager to take this forward. And then myself and the Guardian service are kept updated on progress, on outcomes, and ensuring any lessons learned are captured, shared and implemented. We have had 2 cases managed under the standards in this period. At the time of the report, both cases are still ongoing, so we aren't able to report outcomes. One relates to an investigation which has just been concluded, which is around management concerns in an area of primary care services, and the commissioning officer, which is Fiona Davies, the chief officer in Argyll and Bute, and other SMEs are reviewing that report now. The other related to health and safety matters, and that process was overseen by our Head of Occupational Health and Safety and is in the process of being concluded. There were no specific findings of any concerns, but the outcome has been that action is being taken to make sure that all colleagues are aware of the availability remit and points of contact for local health and safety committees, colleagues who work in that area, and the staff side health and safety reps. So these first cases have let us understand better what's needed to investigate and take forward cases, and we'll continue to build on these processes and systems. And we have in fact just concluded an internal audit into the whistleblowing standards implementation, and that's going to be reported to December Audit Committee, and the sort of final draft report is expected soon. But we've had some initial closing feedback, which has been really helpful in pointing out areas for improvement and future focus in terms of, you know, our processes and and record keeping, but there has been lots of positive feedback about how much work has gone into the whistleblowing standards. We'll continue to promote the standards across the board and with our partners to ensure people know about the Bert Donald, our whistleblowing non-exec, has been really active in promoting this in the media, internally within the organisation, and also with past and future visits across the board area, including to Argyll and Bute. We're also continuing to promote the training that's available online around the standards on 2RAS Learn, and the excellent information available on the Whistleblowing Standards website. So I'm happy to stop there and take any questions or thoughts.
Thank you, Fiona. And can I invite contributions from board members, questions or comments? And Bert.
Thank you, Chair. I think it would be appropriate for me, as the whistleblowing champion non-exec director, just to perhaps add some comments to what Fiona has said. But firstly, my thanks to Fiona for a very comprehensive resume of the work that has been carried out in relation to the implementation of the standards. My role, as everyone will be aware, is one of oversight and governance and assurance. But I think it's also important to highlight the very clear links between whistleblowing and the wider culture programme. I don't see whistleblowing as being a standalone entity, but I do see that it's got this very strong connectivity with the work that's being done in relation to the wider culture agenda. And indeed, the common thread that runs through all of that into patient safety, which I think is a very important element as well to emphasise. This is, of course, the first report that has been provided to the board, but the work in relation to this started a long time ago. Although the standards were formally introduced earlier this year, the organisation has been working hard over quite a long period of time to prepare for this. And I would commend everyone who's been involved in the work to get to the point where we are at today. Not all elements of the standards are in place. I think we understand that, and indeed that has been accepted by the Independent National Whistleblowing Officer and the Scottish Government. But we're working towards that complete implementation, and that work will in fact continue. I think an important part of all of this has been communication. There's been a very effective, very comprehensive communication strategy, but that cannot be a standalone thing, and it cannot be a one-off thing. And this communication will need to continue, and it will need to be an ongoing thing as this journey continues. Turning now to what the report is telling us, we see the numbers that have been reported in the first quarter. The board may want to consider and reflect what these numbers are telling us. What did we expect in terms of numbers in that first quarter? Are these numbers a positive thing, or are they a negative thing? I think there is reassurance to be taken from the fact that 9 people have felt confident enough to come forward, to raise a concern, and to have these concerns properly investigated with integrity and thoroughness. The standards impose quite tight timescales for investigation, and realistically, it's going to be difficult to adhere to these timescales. We've heard earlier in today's meeting about the difficulty in complying with timescales for complaints, and this is no different. Inevitably, inquiring into these things will take time, and it's unlikely that in the majority of cases that the timescales will be adhered to. But what is important, and indeed what has been happening, is that where the timescales are not met, that the individuals who've come forward to raise concerns are being kept and updated at every stage. As Fiona has said, too early to identify trends, too early to look at particular themes, but that's something I'm sure that will come as we move forward, going into reports that will undoubtedly come forward as we move ahead. There is a responsibility on behalf of the IJB, and I note that a report has gone to the IJB for their consideration as well. Fiona referred to the online training package that's available on Turis, and if there is one thing that I could ask, perhaps, it is for continued promotion of the opportunity to learn. 2 excellent training packages there, one for general use and one aimed at those who will be investigating concerns. And I certainly would be encouraging the continued promotion of that opportunity. I think that covers everything that I would want to say at this time. Thank you very much, Chair.
Thank you, Barrett. Give Fiona an opportunity to respond briefly to these points before we bring in others.
Yeah, thanks. And I think first what I would like to say is that Bert is our whistleblowing champion and non-exec. We've really appreciated Bert's willingness to work with us and support us and get involved in this. It's been really beneficial. And particularly his willingness to go out both virtually and in person to talk to people about his role, about the standards. I really think that has helped us to get the word out. You know, we've had really good media and press coverage around the standards, and that's certainly in part, you know, helping us with the awareness of the standards. So I think that's it's been really helpful. There is always more work to do in this area, and I think our particular kind of area of focus at the moment for the ongoing implementation group is around how we make sure that the harder to reach areas are aware of this, and that particularly goes out into primary care, into our sort of independent sectors, and to those who work with us but aren't employed by us. So there's a focused piece of work ongoing with that. But I also think that the ongoing promotion of the standards, and particularly, as you say, of that online training, that, you know, we've got some really good resources out there that have been provided to us by the INWO. So it's really important that we continue to promote and use those.
Thanks, Fiona. I have Sarah, followed by Susan, followed by Alex.
Thank you. And again, this is one of those reports which I've seen, I think this might be my third or fourth time, but definitely still have more questions. And just to reassure Bert, yes, we did. We looked at the full report at the IJB and gave it a good run through. So we were cited on that. Last time I looked at it, which would have been at the IJB, the two cases, the live cases, whatever you want to call them, were kind of not yet at the point where they had come to the end of their investigation, for want of a better way to put it. I'm interested to know, for case specific findings, so where we've investigated it and there's learning that's come out of that, where is that plugging in to the organisation in terms of governance structures? And I'm not suggesting that the detail of each case would come to these higher level committees and boards, but for example, if there's learning that comes out of a whistleblowing investigation, does that get raised in a DATEX, or how does that kind of plug into the operational systems of learning and governance?
Maybe take the other two contributions and come back to you, Fiona. Susan.
Thank you, Chair, and thank you, Fiona, for a really comprehensive report. And I think mine is aligned to something that Sarah has said, because I'm very conscious of the threshold that has to be reached for something to be considered a whistleblowing complaint. But there's also, I'm sure, organisational learning that can come from those cases that don't meet that threshold. So are there trends there, or are there issues that could also be captured that would be useful to us and that we could incorporate into our culture programme? Thank you.
Thanks, Susan. Alex.
Yeah, I agree with both Susan and Sarah, and that was a concern I had. But in addition, it is good to see that we had 9 and the awareness is there because it's spread over an area. I'm a little bit concerned as we move forward, though, that one or two things can happen. When we see the numbers that people are being told, yeah, thanks very much, but that's not a whistleblower issue, then that might switch people off to say, well, I don't know what is and what isn't. Then you come back to education and then training of the people. However, what we don't necessarily want people to be, or try to be, is experts on what is and what isn't whistleblowing. I'd much rather that they came forward with a concern and let the experts decide whether it was or it wasn't. So that very fine balance we've got to, we're aware that we have to strike. And again, we're talking about over a longer period of time. How we get there, that's the challenge for both Fiona and Bert and the other experts in the field. But it's something that I think we need to be very aware of, because we really don't want to switch people off at this point when we've got them starting to help us. Thanks.
Fiona, do you want to respond?
Yeah, happy to do so. So I think, as you say, it's really important for us that we plug in the findings of these cases, whether or not they actually are whistleblowing or not. So we've absolutely got a kind of clear process around that. And as you say, it depends, because whistleblowing can cover a whole range of different issues. We've got a number of different routes for that, for example, into the clinical governance team, into health and safety, into various kind of management teams and committees. One of the benefits I think we have in using the Guardian service for the administration and reporting of our concerns is not only does that give us some dedicated resource to be able to kind of manage this in one place, irrespective of where the complaints arise from, but it also ensures that we do have that one point where we're capturing all of the data. When cases aren't regarded as whistleblowing, there is the option for them to go in as at least one of the cases reported actually into the usual concerns process from the Guardian service, and so that and they report to us on a monthly basis around the outcomes and themes, and there is a clear escalation route that we signed up to with the Guardian service for complaints and concerns to be raised, escalated and resolved within the organisation. So there definitely is a bit of you know, kind of safety net there. I think some of the other cases that we had come through were I suppose they were kind of appeals against things that have been through other processes, and whilst we always have to check to look and see that a proper process has been followed and that there isn't any gaps with that process. Obviously, one of the things we're very clear with on the whistleblowing standards is that it's not another route of appeal for, you know, kind of internal processes such as grievances or other complaints. But again, any of those learnings are captured and fed back in. So I think it's something that as we get more cases coming through, we'll kind of build up more insights, and we'll probably kind of build up stronger processes. I think there's also a link for me that if there was something that was what I would regard as an organisational learning around culture, we would make sure that we use the culture programme kind of action tracker around that as well, because obviously some of the themes we may get coming through from here would be, you know, similar to things that might come through the healing process reports or the wider survey results. So by having one single place where we're tracking specific organisational level actions, I think that helps us. On the final question from Alex, again, I think it's a really important point around, you know, if people raise a concern and it's not whistleblowing, making sure they're not switched off. I think we've put to date quite a lot of time and effort, particularly where something is, you know, one of these cases that I've talked about where maybe it's an escalation of a concern that's already been resolved. We make sure we provide plenty of information. Where we're making a decision, we also provide people with the details of the national INWO in case they want to get a second opinion on it. And again, that link to the Guardian service is really important, because the Guardians can then support people with picking up a concern, even if it's not whistleblowing.
Yeah, thanks, Fiona. Barrett, did you want to come back in?
Yes, thanks, Chair. It was just to respond to the comments from Sarah and Susan and Alex, and Fiona has alluded to some of that. Perhaps I can just emphasise and maybe add a little bit more. The learning and ensuring that the learning is implemented, part of that responsibility comes to me, or is certainly as part of my role, to ensure that steps have been taken to implement learning. And I think for me, one of the things isn't just looking to see whether the learning has been implemented, but it's also about sustaining the learning, which I think is very important. Susan talked about issues which are perhaps not meeting the threshold for whistleblowing. And of course, we've had examples of that. But an important part of the process and of the arrangements that are in place in NHS Highland is the Guardian service have a very important part here to play in relation to directing people to where they might take their concern. And indeed, some of these concerns may be routed through HR processes, or indeed they may be dealt with as business as usual. So I think that's something actually to be reassured about. I think another important point to make, and perhaps to try and address the point made by Alex, is that to try and encourage folk to come forward, the communication that I talked about earlier is absolutely vital. So we've done communication. But as we said earlier on, that communication has got to continue so that people know that the routes are there to raise concerns, and I think we need to continue that as we go forward. Hopefully that addresses the points that have been made. Thank you very much.
Thank you, Bert. And I just want to pay tribute to Bert's own role in all of this, providing another strand of evidence of the issues that are out there through his virtual and actual visits to the communities. That's been very important, and the way he has conducted that is exemplary, and also is an experience which is different in other board areas, and we are very glad that we have a whistleblowing champion that operates in a sensitive but assiduous manner. So thank you to you, Bert, for that, and thank you to Fiona for a full report. And this is first of the quarterly reports, and we would expect to have more data on which to reach some conclusions at the next quarter. Our next item on the agenda is due to be appetite, all about appetite and tolerance, and I'm going to ask what your appetite is like just now and how tolerant you would be of extending the morning or satisfying your appetite. My own inclination is that we should take a break now for half an hour, and if Dr. Peters and Miriam could come along in the early afternoon to contribute to these two items. That would be the best way. Okay, right, let's have a break for till 20 to 2.